Hello, my name is Wendy Ziai. In this video, we are going to demonstrate the technique for the MISTIE-III trial for TPA injection into the hematoma cavity. In this procedure, we will inject tissue plasminogen activator, TPA, and flush using 2 syringes and a stopcock in a single connection technique. This method is the same one used for sterile intraventricular injection of TPA in the CLEAR IVH trial, but does not include aspiration of hematoma contents. The pharmacist will prepare the TPA and flush, which will be sent in 2 small syringes. The first step is to compare the labels on the syringes with the patient's identity and ensure that the TPA dose is 1 milligram per ml. The flush volume should be at least 3 milliliters and consist of non-bacteriostatic, also known as preservative-free saline. Notice that at this point I have washed my hands, put on a mask, hat, gown, and sterile gloves, and placed a sterile drape on the field. I am now going to prepare the intracranial catheter and stopcock with antiseptic solution. We use a providone iodine solution, although betadine and chlorhexidine-based solutions have also been used as the standard of hub care for intraventricular and intrathecal catheters and are also acceptable. Please follow guidelines for your center. Next, the TPA and flush syringes are attached to the stopcock. Current procedures for preparing products for intrathecal administration in the United States ensure that only the contents of the syringes are sterile. The outside of the syringe has a non-sterile label and comes in a non-sterile bag. When bringing the syringes into the sterile field with the 3-way stopcock apparatus, care should be taken to ensure the exterior of the syringes does not touch the catheter port or gloves that may touch the port. This may require a change of sterile gloves after placing the syringes on the stopcock. The goal in this regard is to ensure the sterility of the fluid and fluid pathway to the hematoma cavity. The injection apparatus is assembled by attaching the stopcock to the screw port closest to the patient's head. The apparatus screws directly into the port on the catheter system. Some hospitals may still use a needle port for injection. In this case, use a 25 gauge needle to puncture the port. This setup allows injection of TPA and flush with a single connection to the system. At this point, notice that just below the rubber port is a 3-way stopcock. In our system, the portion of the stopcock that moves in this direction is toward the patient, and the tubing from the stopcock going in this direction is towards the collection bag. This stopcock should be closed to the drainage bag for the injection procedure. You will also notice that the slide is closed here, which again prevents fluid from accidentally going backwards toward the drainage system. The only route is for fluid to go into the patient. Once we've adequately prepared the port, I like to grab the port with gauze like so, and then I can take the injection apparatus and access the port like this. Now we are going to turn this stopcock so that when you inject the TPA, it will go directly into the patient. And so I gently inject the study drug over approximately 60 seconds. Now that the TPA is injected, I close the stopcock again and turn this stopcock so that I can then flush slowly with the 3 milliliters of flush, like so. And this allows us to be certain that all of the TPA actually enters the hematoma cavity around the catheter. This flush volume is based on Medtronic 33 centimeter intraventricular catheter tubing with an internal diameter of 1.7 millimeters. If your EVD drainage equipment differs significantly from the measurements for this tubing, you should calculate the volume of flush required to ensure intrahematomal delivery of the study agent. Also, if the entry port is far from the cranial catheter, the dead space will be larger and may require adjustment of the flush. And with that, we are done with the procedure. We unscrew the injection apparatus from the port and replace the cap and keep the catheter clamped for 1 hour before opening to resume drainage. Notice that we do not monitor intracranial pressure with this catheter and that the drainage bag should be placed to gravity at a level or pop-off of 0 to -5 millimeters mercury for this therapy. This information should be explained to the nursing and physician team to ensure drainage is maximized and efficient. Thank you.